the purpose of ARCHES was to demonstrate that enzalutamide had clinical benefits in men with metastatic hormone-sensitive prostate cancer. Previous trials had demonstrated improved survival in men with metastatic castration-resistant prostate cancer, both after chemotherapy, before chemotherapy, and even in men without metastatic disease by conventional imaging. The ARCHES trial was designed at a time when all we knew was that docetaxel improved survival in addition to ADT in this metastatic hormone-sensitive setting. And so part of the design was to allow men to have completed docetaxel. About 20% of ARCHES patients had prior docetaxel. But we also allowed men who had high volume disease, low volume disease, men who did not choose to receive docetaxel, men with de novo disease, metastatic disease at diagnosis, or men with relapse disease after radical prostatectomy or radiation. So a very diverse global patient population of 1,150 men. The primary endpoint was designed around radiographic progression-free survival, which is the amount of time a man has before his disease develops, basically castration-resistant disease based on imaging, bone scans, and CTs, or death, which is a clinically relevant endpoint that changes our practice. And the FDA approved enzalutamide in this setting about 2 years ago now, based on the primary results of ARCHES. And at ESMO this year, we presented the final overall survival results, which were presented even after crossover of patients once this trial was read out unblinded, and patients were often offered open label extension enzalutamide. Well, the key findings and take-home messages were that despite the crossover of many of the patients and the subsequent use of life-prolonging therapies in patients initially treated with ADT and placebo, enzalutamide extended overall survival by about 30 to 40%, a hazard ratio of 0.66. This met the pre-specified statistical criteria for a positive study for this key secondary endpoint, suggesting that enzalutamide improved overall survival by about 34%. And it did so in most of the subgroups analyzed based on disease volume, prior therapies, geography, age, functional status. There were some notable subgroups that are clinically important, such as the men treated with prior docetaxel and based on pattern of spread, where clearly we see a survival benefit in men who did not receive prior docetaxel. We see improvements in radiographic progression-free survival and a suggestion of improved survival in patients who had prior docetaxel, but the confidence intervals are wide in this smaller subgroup population. And I think future studies will be needed. We saw at ESMO data from the PEACE study. Data for enzalutamide is likely to be still forthcoming in combination meta-analyses, perhaps with other studies like ENZAMET, where this question can be addressed with a larger sample size and longer follow-up for this very important question of really triple therapy. Is there a benefit in this group of patients, particularly with high volume disease who have completed docetaxel? And the question is, can they live even longer if they have an AR inhibitor such as enzalutamide? We see from the PEACE study that abiraterone has extended this survival, and there's a suggestion both from ENZAMET and from our study that there may be a benefit, but further follow-up and data pooled across studies may be helpful for this question. There's also the pattern of spread question. We see clear survival benefits in patients with lymph node and bone metastases, which is the vast majority of ARCHES patients. There's a group of patients, particularly with liver metastases, that seem to have suboptimal outcomes with AR targeted therapies, either with Abi, Enza, or apalutamide. And in these patients, I do strongly consider the use of chemohormonal therapy with docetaxel. We did not see a clear survival advantage in these patients in the ARCHES analysis, although it's a very small subgroup. And I think, it's reasonable to consider more aggressive approaches for these patients, such as with docetaxel and an AR inhibitor subsequent to that, where these patients may have more durable benefits. We also reported updated safety results where you do see side effects related to enzalutamide, particularly hypertension, fatigue, mild cognitive, grade 1 to 2 side effects. You see slight increases in the risk of falls and fracture, which were consistent with our primary endpoint, but with much longer follow-up and duration of treatment. It's not surprising that the enzalutamide patients have slight increases in these more grade 1 and 2 side effects. Fortunately, The cardiovascular risk profile was very safe. And I think with survivorship measures to reduce the risks of these side effects, like exercise and diet, bone density monitoring, and prevention of bone fractures, I think we can minimize these side effects. Well, they already have. The good news is that this drug is approved. This updated data around survival just adds more weight to the benefits of using AR therapy early in the disease process. We also saw from ESMO that perhaps using an AR therapy in the curative intent setting with radiation in localized high-risk patients may extend survival. So I think overall, we're seeing the AR inhibitors, these potent AR inhibitors, move earlier and earlier with the goal of curing more men, with improving survival for most men now, and allowing men more time with their families and loved ones and to enjoy life.